today, maybe around 11:30. So what I'm going to do is I'm going to go through without a break. If anybody's got to get out, take a break, go to the bathroom, something like that, I understand. I'd like to go through without stopping, if that's okay. Okay, so we didn't finish up the preliminary stuff last time, so what I'm going to do is I'm going to just basically, their treatment of it is pretty good. I just want to supplement a little bit of some of their coverages and point a few things out so that we get to the renal material as soon as possible. We had talked about pharyngitis. The next topic that they take up is laryngitis. In the context of laryngitis, they do talk about the effect of GERD, and you should be aware that patients that have GERD-associated respiratory symptoms may also complain of heartburn, and they can also have a nocturnal cough. So a nocturnal cough should at least trigger in your mind the possibility that you might be dealing with somebody that has GERD. In terms of epiglottitis, which is discussed at the bottom of page 43, you should understand that's obviously a very serious illness and one that you need to recognize and handle appropriately in the pediatric population. And the differential diagnosis is going to be between that and viral croup, C-R-O-U-P, which is basically viral laryngotracheal bronchitis. Much more benign course, but you do need to distinguish those. Two entities. I'm going to skip over the treatment of bronchitis, bronchiolitis, and pneumonitis, not because it's not important, just because I don't have anything to add. So go ahead and take a look at that. Now let's talk just very briefly about pneumonia. In approaching the patient with pneumonia, and of course you're going to think about patient having pneumonia if they have fever, chills, cough, sputum, dyspnea, maybe pleuritic chest pain, okay, maybe hemoptysis, depending on what kind of pneumonia. It helps to think about pneumonia in terms of broad categories. Okay, so one can distinguish, for example, between community-acquired pneumonia, which is the pneumonia that people, like the name suggests, acquire in the community, and then nosocomial pneumonia. And nosocomial pneumonia refers to pneumonia that is acquired either in the hospital or in a healthcare facility, like a nursing home. And we can also talk about a subcategory of that, which is ventilator-acquired pneumonia. Okay, so patients that are on the ventilator who get pneumonia are prone to the development of pneumonia with certain agents. I'm trying to remember. I think in order for somebody to get hospital-acquired pneumonia, they have to have been in the hospital, I believe, for 24 hours before you call it hospital-acquired pneumonia. The same thing with ventilator-acquired pneumonia. I'm pretty sure it's 24 hours. So if they're diagnosed with pneumonia 6 hours after they get to the hospital, it's not a hospital-acquired pneumonia because they were probably brewing that pneumonia out in the community. Okay, that's why it matters. In terms of, again, the clinical approach to patients, so you want to decide, am I dealing with a community-acquired pneumonia, am I dealing with a hospital-acquired pneumonia? You also want to find out whether the person has risk factors for certain other types of pneumonia that you need to deal differently with. So, for example, they talk about the possibility of aspiration. Patients can aspirate. Patients who are unable to protect their airway and aspirate can develop an aspiration pneumonia. So alcoholics can do that. People that have seizures, people that have loss of consciousness for whatever reason, patients with a drug overdose. And the reason that matters is that they can develop pneumonia with certain anaerobic agents. And so you need to cover for anaerobic agents in patients in whom you suspect the possibility of an aspiration pneumonia. They talk about a couple of different common causes of pneumonia, including community-acquired pneumonia, so streptococcus pneumonia or pneumococcus, which you can, there's now a urinary antigen test to identify. They talk about Legionella pneumonia, which is going to be important in certain patient populations. That also has a urinary antigen test that's available to make the diagnosis. As you know, influenza, you can do a nasopharyngeal swab to identify patients that have influenza. And then many of the other pneumonias you have to identify either on a sputum culture or a blood culture. The patients that have community-acquired pneumonia, unless they have a reason not to treat them with macrolides, are usually treated with empiric Zithromax. If somebody has a hospital-acquired pneumonia or a ventilator-acquired pneumonia, we need to be more concerned about the possibility of a methicillin-resistant Staph aureus pneumonia. We need to be concerned about the possibility of a gram-negative rod pneumonia, and we need to be concerned about the possibility of a Legionella pneumonia. And so the coverage, the empiric coverage, while we're waiting to identify the organism, the responsible organism, is going to be broader, right? And you'll talk about that in pulmonology and maybe microbiology and clinical medicine. Okay, so let's talk about, just very briefly about tuberculosis. Tuberculosis, like vasculitis, like alcoholism, like syphilis, is one of those diseases that if you understand tuberculosis, then you have a pretty good understanding of medicine. Tuberculosis has taken the lives of innumerable famous people, but some of the people that you may be most familiar with who tuberculosis has claimed their lives. Stephen Crane, you probably read Stephen Crane writings in high school, Red Badge of Courage, The Open Boat. Ringing a bell for anybody? Okay. George Orwell, 1984. Okay. Washington Irving, what are all those stories that we like to read around Halloween time. And then a writer, a Russian writer whose writing you'll be reading as part of the ethics course, Anton Chekhov, also died of tuberculosis. They talk about a couple of things in their discussion. They talk about the Goen focus and the Goen complex. What you have to recognize about, one of the things you want to realize about that is the sequela of a primary tuberculosis infection, primary pulmonary tuberculosis. It's a leftover or remnant of primary tuberculosis. Not everybody who has primary tuberculosis goes on to develop a Goen focus or a Goen complex, but about a third of the patients do. They talk about that the risk of a recurrence or reactivation is about 5% per year in the normal population, but that risk goes up in certain patient populations. So it goes up in the elderly, and it goes up in patients who are immunocompromised, which is why if you put somebody on prednisone or steroids, you always need to make sure that they're not carrying latent tuberculosis. And that's why the commercials on TV say, talk with your doctor before you start, Humira or whatever else they're advertising these days. All those immunosuppressive agents. Talk to your doctor, make sure you don't have a history of TB. Okay. Their discussion of lung cancer is fine for its purposes. They distinguish between small cell and non-small cell lung cancer, and the differences in terms of prognosis. They also talk about the association of, they talk about the different ways lung cancer can cause symptoms, and they talk about the association between lung cancer and paraneoplastic syndromes. Most of the paraneoplastic syndromes associated with lung cancer are associated with small cell lung cancer or oat cell lung cancer, okay? But one of the paraneoplastic syndromes that we've already, I think we've already alluded, no, we haven't alluded to it yet. One of the paraneoplastic syndromes is actually more common in squamous cell lung cancer, and that's the paraneoplastic syndrome associated with hypercalcemia, PTH-related protein. Among the paraneoplastic syndromes that they discuss, take a look at them. Some of them we will discuss going forward, but some of them we did allude to in the past. So, for example, the Lambert-Eaton syndrome. Remember when we talked about, in neurology, we talked about the Lambert-Eaton syndrome, distinguishing it from myasthenia gravis. Oh, by the way, one other thing to take note of is that besides, they give you reasons that patients with lung cancer can develop symptoms, pulmonary symptoms, they can develop constitutional symptoms, symptoms related to compression, symptoms related to paraneoplastic syndrome. They can also develop symptoms related to metastatic disease, okay? So somebody with a lung cancer could present with a seizure, bless you, and it's from a brain met, okay? So you need to be aware of that possibility as well, that they can present with symptoms of metastatic disease before they present with symptoms of anything else. Okay, diseases of the pleura. There are two pleural surfaces. There's the visceral pleura and the parietal pleura. And as you probably know, the pleura is basically, the best way to think about it is as imagine a balloon that you stick your fist into, okay? And you invaginate the balloon, and what you end up with is two very closely approximated surfaces. In fact, they're touching each other, and the space between them is only potential, maybe a little bit of lubricating fluid. That's the pleural space, okay? Same thing with the pericardial space. So there's the visceral surface, which touches the lung, and then the parietal surface, which is in contact with the chest wall. The first disease that they talk about is pleurisy, and I think their treatment of that is fine. In terms of pleural effusion, I do want to supplement it a little bit. They distinguish between two different types of pleural effusion, and this is important in clinical practice as well. You need to distinguish between transudative pleural effusions and exudative pleural effusions. Okay? Transudative pleural effusions, if you remember when we talked about the Starling forces that act at the level of the capillary, right? And we have the hydrostatic pressure, which tends to push fluid out into the interstitium, and then you have the oncotic pressure of the proteins, which tend to pull fluid back in. Remember that? And then you have the permeability of the capillary. Depending on how permeable that is, it's going to play a role in terms of how much fluid crosses over into the interstitium. Okay? So patients that have transudative pleural effusions have no change in vascular permeability. Okay? So the problem is going to be hydrostatic pressure and oncotic pressure. Okay? Whereas patients that have exudative, pleural effusions have a problem with capillary permeability. And so, as you might imagine, if you have a problem with capillary permeability, you're going to get leakage of protein out into the pleural space. And so, the way you can distinguish between exudative, or the way we distinguish between exudative and transudative pleural effusions, is by using these criteria called the Lights criteria, which are discussed in your book. According to those criteria, the fluid is said to be exudative if any of the following criteria are met. Any of them. First of all, if the ratio of the pleural fluid protein to the serum protein is greater than 0.5, or if the ratio of the pleural fluid LDH to the serum LDH is greater than 0.6, or if the pleural fluid LDH is greater than 2/3 the upper limit for the serum LDH. So what that tells you is that when you try to distinguish between an exudate and a transudate, what you do is you're going to have to do a thoracentesis. You're going to have to remove some fluid from the pleural space, and you're going to send it to the lab, and you're going to ask them to run pleural LDH, pleural protein, okay? And you're going to send for other things as well. You're going to send for, because we're not only concerned about finding out whether it's transudative or exudative. We also want to find out, well, what's causing it? You know, whatever it's, whether it's transudative or exudative, what is causing the pleural effusion? So you're going to send also for a glucose, the pleural fluid glucose, for a pH, amylase, cell count with a differential, and if cancer is in the cards, if it's a possibility for a cytology, send for a cytology as well. Obviously, culture if you're concerned about infection. Remember too that besides sending all of this, all of the pleural fluid, you have to send a sample of blood at the same time, because you want to compare the pleural fluid LDH to the serum LDH and the serum protein. Everybody see that? All right, so you're going to get pleural fluid LDH and protein, as well as glucose, pH, amylase, cell count, differential, cytology, maybe culture, okay? And then you're going to get the blood LDH and protein. Some of the causes of a transudative pleural effusion, what might you think might cause a transudative pleural effusion based on this?
Fluid overload.
What's that? Yeah, fluid overload. So congestive heart failure you can do it. Nephrotic syndrome, again because of decreased oncotic pressure, okay? Nephrotic syndrome can do that as well. Liver disease, cirrhosis can do that as well. In terms of exudates, what might you think would cause exudative effusions?
Cancer, infection.
I'm sorry?
Cancer.
Malignancy can do it, absolutely, because you get impairment of the you can get especially if you have like a seeding of the pleura with the metastatic disease. Yeah, malignancy can do it. Infection can do it. Well, you mean if you have blood in there? If you have trauma and you have blood, to the extent that you have blood, then if you look at the Lice criteria, the more the pleural fluid looks like blood, the more it's going to be deemed to be exudated. So, but when it's obvious trauma, we don't really worry about if it's exudated. It's obvious that it's trauma. Okay, let's talk a little bit about different types of pleural effusion. Talk about a couple of. They do a good job. I just want to elaborate on a couple of points. If somebody has a pneumonia and they have a coexisting pleural effusion, so they have pneumonia and they have a pleural effusion at the same time, or a lung abscess and a pleural effusion, so they have parenchymal lung disease, an infection in their lungs, and they have a pleural effusion at the same time, they are said to have a parapneumonic effusion. Parapneumonic effusion. Now it's important to recognize that because you have to distinguish between complicated and an uncomplicated parapneumonic effusion. Okay? A complicated parapneumonic effusion is any parapneumonic effusion in which an invasive procedure is going to be needed for resolution. So these would be, for example, patients that have a positive culture. So the culture from here is going to be positive. The pleural fluid culture is positive. The glucose is low. The glucose is less than 60. pH is less than 7.2. Or the LDH is more than 3 times the upper limit of normal. More than 3 times the upper limit of normal. Those are indications that the patient's pleural fluid, their effusion will not resolve without an invasive procedure like thoracentesis or placement of a chest tube. Okay. So you want to distinguish between a complicated and an uncomplicated paralytic effusion. And there are criteria. So what you do is you have a patient like that has pleural effusion. You'll get a decubitus film, have them lie down, and then depending, I can't remember the exact criteria, but depending on how much that layering is, it has to be a certain minimal amount. And if you actually get a certain minimal amount of layering that you can measure, then you say, okay, that's a significant effusion. I need to do something about it. I need to see if it's a complicated or an uncomplicated paralytic effusion. So you don't want to miss that, because otherwise, it's going to turn into an abscess. You don't want that. Okay. Okay, a couple of other things. We're on page 46 now. We're talking about the chylothorax. Chylothorax refers to a collection of lymph in the pleural space. It can be traumatic or it can be non-traumatic. The traumatic causes of chylothorax are usually iatrogenic. So a person has surgery, and during surgery there's injury to the thoracic duct, and you get chylothorax. But the most common non-traumatic cause of chylothorax is malignancy. They point out in your book that hemothorax, which refers to blood in the pleural space, can occur from trauma or from a ruptured aortic aneurysm, but you can also get that from a pulmonary thromboembolism. So if you have let's say this is lung here, okay, and let's say you get an embolism and it's peripheral, so you get an area of infarct here in the lung. And so if the lung tissue is dead, sometimes you can get exudation of blood into the pleural space. So pulmonary embolism with an infarct can cause hemothorax, and malignancy can do that as well, as you might imagine. Okay. Just a couple more things. I know you've learned about and demonstrated in physical diagnosis E to A changes. Just to talk a little bit about the pathophysiology of that, or the physiology of that, it's reportedly caused by enhanced transmission of high-frequency noise across abnormal lung tissue, and A is a higher frequency than E, which is a lower frequency and gets filtered out. And let's see. I think I've shown you pictures of this before. Remember, clubbing refers to the angle that the proximal nail makes. So here's the nail. Let's see that. Here's the finger, the end of the digit. Here's the nail over here. So the angle here is what you're looking at to see whether somebody has clubbing or not. So I'll show you some examples of clubbing. Okay, so this is a good one. Okay. Okay, yeah, you can put them together to see if there's still a space to see through. That's a commonly performed test. There's no baby seals here. I don't see any baby seals. Oh, here's a good one. Here's a good one. All right, that's a good one. You see that angle right there. Okay, effacement of that angle right there. That's a really good picture. Okay.
So does the angle become more than 180 or less?
Well, it should be. Well, it depends on how you measure it, but it should be. You know, like a V. It's, what is that called?
So
concave, and then it becomes straight or convex up. Okay. The other thing is the mnemonic. The mnemonic for clubbing. Okay. So there's different mnemonics. Okay, but you can look them up yourself, whichever one you're most comfortable memorizing. But I'll give you one of them. Okay, clubbing, C-L-U-B-B-I-N-G. First one is the C is cyanotic heart disease. The L is lung disease, and the lung disease can include lung abscess, lung cancer, bronchiectasis, cystic fibrosis. Okay. The U is ulcerative colitis. Then you have two B's. One is biliary cirrhosis. We'll talk about that when we get to GI, but biliary cirrhosis can be associated with clubbing. And the second one is birth defect. Okay, and that means that the person can be born with clubbing, and that apparently is benign. Okay, so that you have to keep in mind that the possibility that the person's had it since they were born, then maybe not a cause for concern. The I is infective endocarditis. So we talked about that before. That's another physical finding besides the Ross spots and the Janeway's lesions and the everything else that we talked about. Murmur. The N is neoplasm. So other neoplasms besides lung cancer can be associated with clubbing, including Hodgkin's disease. And then the G stands for GI malabsorption, as you might see in celiac disease. Okay, so cyanotic heart disease, lung disease, ulcerative colitis, biliary cirrhosis, birth defect, infectious endocarditis, neoplasm, and GI malabsorption. Yeah.
Did you mention some specific lung diseases?
Yeah, we mentioned, bless you, lung abscess, lung cancer. We mentioned bronchiectasis, cystic fibrosis. There's a whole bunch of lung diseases that can be associated with that. In fact, let me see. Let's see. I think there's one that actually expands the lung abscess one. It's just mnemonic. Let's see. This one. So here's another one. And so they expand the lung disease, lung abscess, bronchiectasis, cystic fibrosis, COPD, empyema, and I guess fibrotic lung disease. So this is on Facebook. All right. What?
It says don't say COPD.
I know, because some of these mnemonics are just stupid. How are you going to remember that? How are you going to remember that it's instead of saying COP, underline the D, which makes more sense, right? Don't say COPD. I don't know. But COPD might be a cause, okay? All right. Any questions about that before we go on to, any questions about anything that we talked about with regard to pulmonary before we go on to the renal system? Okay, all right, so we'll move on to the renal system. So the chapter begins with an overview of kidney function. They talk about the role that the kidney plays in different physiologic functions. It might be a good time at this point in time to talk about some of the indications for dialysis, the indications for hemodialysis. Like when do you need to dialyze somebody if the kidneys fail? Okay, that might be another way to remember some of the things that the kidneys do, some of the important roles that they play. And there's different mnemonics for that, but one of them is AEIOU. Okay, so I think, let's see, the A stands, I think, for acidosis, intractable acidosis. The kidneys are responsible for, one of the things that the kidneys are responsible for is maintaining, along with the lungs, acid-base balance. So intractable acidosis, you cannot control the acidosis in any other way. In a patient that's in renal failure, you may need to dialyze them. The second one is electrolyte abnormalities, particularly hyperkalemia. Okay, patients who develop renal failure, one of the things to worry about is hyperkalemia. They can also develop abnormalities with potassium and calcium, sodium and calcium, and other substances. But intractable hyperkalemia would be another reason to dialyze them. Let's see. The O is volume overload, intractable volume overload, because the kidneys are responsible for volume. The U is uremia, the symptoms of uremia. So they could have nausea, vomiting, they can have confusion, they get real twitchy when they can get, the liver flap that you get after ictus. You can get that in patients that have uremia as well. And they can have seizures, and also associated with uremia and the failure of the kidney to detoxify many of the substances that it usually does, they can develop something called uremic pericarditis. So we didn't talk about uremic pericarditis because I brushed over pericarditis, but one of the causes of pericarditis is uremia. So if you have somebody that's in renal failure and you're trying to decide, do I need to dialyze them today, you want to listen to their heart and make sure that you don't hear a rub or anything, okay? And they can have bleeding diathesis associated with that uremia. So they can be symptomatic from the uremia, they can have seizures, they can have uremic pericarditis, they can have a bleeding diathesis, which means it's hard to control the bleeding. What am I missing?
Aye.
Yeah. What's the other one?
Infection.
Huh?
Would be infection.
Blank infections. Does anybody remember what it is off the top of their head? I'm blank. Huh? Yes, intoxicants. It's poison. So sometimes there are some poisons. If somebody comes in with a poison that is dialyzable, then you may, apart from renal failure, this is somebody comes in with a poison, even if they have normal kidneys, you may have to dialyze them. So for example, salicylate poisoning, aspirin toxicity, lithium I think is another one. So certain intoxicants are reasons to dialyze people, but the other ones are the ones that you worry about in patients with end-stage renal disease.
What was that other one you said?
Intoxicants?
Yeah, the second one. Salicylates and what?
Lithium?
Oh, lithium, thank you.
Okay. All right, let's talk about acute renal failure, which nowadays is, I guess, referred to as acute kidney injury. And acute kidney injury is diagnosed by the following criteria. If the creatinine rises by more than or equal to 0.3 milligrams per deciliter in 48 hours. So the creatinine is going to be reported on the SMA6 or the BNP in terms of milligrams per deciliter, 1 point something, 0.9. So if the creatinine rises by greater than or equal to 0.3 milligrams per deciliter in 48 hours, that's consistent with acute kidney injury. If the creatinine rises by more than 1.5 the baseline value over 7 days, the prior 7 days, that's consistent with acute kidney injury. So for example, if somebody has a baseline, somebody has a baseline creatinine, let's say of 1, okay? And then they come in, 7 days later, and they give you this history that they've been doing something that's not good for their kidneys, like taking some agent like NSAIDs or something like that, and their creatinine now is 1.6. okay, then that would be consistent with that, all other things being equal, that would be consistent with acute kidney injury. And then finally, a urine volume less than 0.5 milliliters per kilogram per hour for more than 6 hours. So that's oliguria, okay? Is also consistent with that. So for example, if somebody weighs 70 kilograms, and they're producing 0.5, they should be producing 35 mils, at least 35 mils per hour. So let's say that they're producing 10 mil. Let's say after 6 hours they produce 60 cc's of urine. That's not good, okay? In a 70 kilogram man, that would be consistent with acute kidney injury. Okay, the approach to the kidney with the patient with, yeah, go ahead, I'm sorry. More than 1.5 the baseline, its baseline value over 7 days. So somebody might have let's say somebody has a normal, their baseline creatinine is 2 because they have renal insufficiency, have chronic renal insufficiency. So then acute kidney injury on top of that would require that it go up to 2 times 1.5, which is going to be 3. Okay. Okay, so there's 3 different kinds of renal insufficiency. There's pre-renal insufficiency, also referred to as pre-renal azotemia. There's intrinsic renal disease, and then there's post-renal. And these are illustrated in figure 3.2 on page 49. And we'll talk briefly about each of these. In terms of pre-renal azotemia, we talked about one cause of pre-renal azotemia. Do you remember when we talked about the heart? Anybody? So you can have hypovolemia for any reason, but for example, heart failure is associated with a decreased effective circulating volume. So those people might be they might have a total body water overload, because if you look at them, their ankles are swollen and their legs are swollen, their lungs may be wet, okay? But if you look at from the standpoint of the kidneys are dry because cardiac output is down, and so they have a decreased effective circulating volume. So you can see pre-renal azotemia with congestive heart failure. You can see pre-renal azotemia with liver disease, cirrhosis. You can see pre-renal azotemia with nephrotic syndrome. Okay, again, decreased effective circulating volume. The point that they make in the book, which is important to remember, is that these people have normal kidneys. The problem is that the kidneys aren't getting enough blood. That's pre-renal azotemia. Now the kidney has ways of protecting itself. So you have the vessel coming in here, and then you have the glomerulus here, and then you have the vessel coming out here. Okay, the pre-glomerular arteriole, the post-glomerular arteriole, and the urine's going to be made up from here, and then it's going to go into the tubule. But actually, I didn't do this wrong. You get the glomerulus over here, and then you get the tubule collecting the urine. Okay, so. If this is direction of blood flow, okay, one way you can maintain the way that urine's going to be made here is by transudation, basically, right? Okay, that's one of the ways that it gets made. So the greater the pressure over here, the more urine gets made over here. Everybody see that? Okay, the greater the pressure over here, okay? You can increase the pressure here by increasing the flow, right? So decreasing resistance of the preglomerular arteriole. You dilate that, you get more urine, okay? What happens if you dilate this one? You decrease urine because, again, the fluid, think about it this way, you can either make urine or you can send the blood back to the postglomerular arteriole. So if you dilate the postglomerular arteriole, you make less urine. If you want to make more urine, you got to constrict that. If you constrict that, you're basically squeezing the urine out here. You see that? Everybody see that? Mm-hmm. So anything that dilates the preglomerular arteriole is going to tend to produce more urine. Anything that constricts the postglomerular arteriole is going to tend to produce more urine, and things that do the opposite effect have the opposite effect. So, non-steroidal anti-inflammatory drugs interfere with prostaglandin-mediated relaxation of this. So prostaglandins cause dilation of this vessel. Okay? If you give somebody NSAIDs, like Motrin and all of those things, then you interfere with this dilation, so it's going to tend to produce a decrease in urine production. Okay, so that's one of the mechanisms that NSAIDs can cause problems with the renal function. Patients who are on ACE inhibitors, okay, they can have problems with renal insufficiency if they are dependent on postglomerular constriction for the production of urine. If they're compromised and they need these vessels squeezed down in order to make urine, okay, and you put them on an ACE inhibitor, well, this is going to be angiotensin II dependent, renin-angiotensin aldosterone. This is going to be, remember, angiotensin is a vasoconstrictor, okay, besides producing aldosterone. So that's the mechanism of angiotensin converting enzyme inhibitor renal insufficiency. NSAIDs, ACE inhibitors, okay? They work on different vessels, all right? Anybody have any questions about that? Yeah.
So ACE inhibitors would constrict both sides of the arterioles?
I believe so. I think so.
So then that just be reduced blood.
Yeah, I think that's true. I don't know if there's a difference in terms of sensitivity or not. Okay, the way one recognizes pre-renal azotemia, of course, you're going to take a history, you're going to do a physical exam, and you might suspect pre-renal azotemia based on the clinical circumstances. So, for example, patient has congestive heart failure, patient has nephrotic syndrome, patient has cirrhosis, or patient is an old person who, hasn't been eating or drinking anything for the last couple of days. Okay? So again, there's something about the history that's going to make you suspect it, and then you're going to look for evidence of support that on physical diagnosis. So the tenting of the skin, you may see tachycardia if they're truly depleted. You may see orthostasis. Okay, you see a dry buccal mucosa. There's loss of axillary sweat, tenting of the skin. All of these things that support flat neck veins. All of these things that support pre-renal azotemia. And again, they don't have to have flat neck veins to have pre-renal azotemia because they might have, for example, congestive heart failure. In terms of confirming pre-renal azotemia as a diagnosis on laboratory testing, what you do is you look at, there's a couple of things that you can look at. One of them is the urine sodium concentration. Another thing you can look at is the ratio of BUN to creatinine. And the other thing you can look at is something called the fractional excretion of sodium. So we'll talk about each of these things in turn. First of all, the BUN to creatinine ratio. In patients that have pre-renal azotemia, the ratio of BUN to creatinine, as a rule, as a general rule, is greater than or equal to 20-1. So if the BUN that's reported on the basic metabolic panel is, let's say, 30, and the creatinine is 0.9, okay, then that would be, in a person that has pre-renal azotemia, okay, in a patient that has azotemia, that would be consistent with pre-renal azotemia, okay? A BUN to creatinine ratio of greater than 20-1. And the reason that they get that, that's explained in the footnote at the bottom of page 48. So take a look at that. They do a pretty good job explaining that. With regard to the urine sodium concentration, patients that have pre-renal azotemia have a urine sodium concentration of less than 20 milliequivalents per liter. And if you think about it, that makes sense. And the reason it makes sense is the following. Remember I told you that sodium is responsible for osmolality, but sodium metabolism is not. Water is responsible for volume, but water metabolism is not. So the way that the body controls volume, the way that it monitors volume and controls volume, is by regulating sodium. So if somebody has pre-renal azotemia, if they're dry, the kidneys are dry, what are the kidneys going to try and do? They're going to what? They're going to try and hold on to sodium avidly because sodium equals water later on, right? So the kidneys are going to try to hold on to sodium as avidly as they can. So you'd expect the urine sodium concentration to be low. So less than 20 milliequivalents per liter is a magic number, okay? And then finally, the fractional excretion of sodium. I'm not going to spend a lot of time trying to explain that. They do explain it in the book, but the fractional excretion of sodium is actually more specific. And if you read their discussion on page 49, it's a very good discussion. It talks about how it gets around. The urine sodium concentration works fine until the ADH system kicks in. Remember that we said that ADH, antidiuretic hormone, is also known as vasopressin, and antidiuretic hormone does a couple of things. It causes vasoconstriction, and it causes the reabsorption of water, okay? Now normally ADH works to help regulate osmolality. It's all about water, the antidiuretic hormone. It normally tries to regulate osmolality. But in extremis, in extreme situations, when there's a real volume challenge, okay, then it can be called upon to help solve the volume problem. So for example, I gave you the example before. If you got bit by an animal in the wild, okay, it doesn't do you any good to die with a normal serum sodium, right? So what the body will do will be to sacrifice a normal serum sodium in order to get volume back towards normal. So what's going to happen is that you're going to vasoconstrict like mad, and you're going to start reabsorbing water to give you some volume, okay? Well, what that does is that screws up the urine sodium, because it might lead to a falsely concentrated sodium in a person who really, a higher serum sodium in the urine, a higher sodium concentration in the urine than you'd expect. You see that? Because if you're absorbing free water, the sodium that's left behind in the urine is going to get more concentrated. So the concentration could go from 15 to 20 to 25. It could go, and then it's all of a sudden it's outside the range of what you'd expect to see in somebody that has pre-renal azotemia. And so to get around that, you calculate the fractional excretion of sodium, which basically gets rid of that problem. Okay, so you don't have to worry about that. Okay, so that's why the fractional excretion of sodium is more specific, more sensitive for identifying pre-renal azotemia. And you'd expect to see a fractional excretion of sodium of less than 1% in a patient that has pre-renal azotemia. And you should be able to you should know these numbers, and you should be able to calculate them, okay? Okay, any questions about prerenal azotemia? The second type of renal failure is intrinsic renal failure. So these are people that have a problem with the kidney or kidneys themselves. The problem is not the volume that's being delivered to the kidneys or anything that's happening after that. The problem is the kidneys themselves. And they divide the causes of intrinsic renal failure into tubular interstitial disease and glomerular disease. I think we talk a little bit more about this. We'll talk a little bit more about this later on. Let's see. Actually, wait a minute. You know what? I guess I jumped the gun here. The next thing that they talk about is post-renal failure. Before we talk, all right. So let's talk about post-renal failure before we talk about intrinsic renal disease. Okay. So post-renal failure refers to patients who have a problem after the kidneys. I hit the kidneys, there's the ureter, and then you got bladder, and the urethra. Okay? So for somebody to have renal failure because of post-renal failure, you have to either obstruct both kidneys, because if you obstruct one kidney, you'll kill that kidney if you don't do anything about the obstruction. But the other kidney will take up the slack, so you won't see a marked rise in the indices. Okay. So in order to have renal failure, okay, you either have to have bilateral obstruction. Okay. So you have to have something maybe down at the level of the bladder or the urethra. Okay. Or you have to have unilateral obstruction in somebody that has a solitary kidney. Okay, and you can have diseases that obstruct the post-renal cause post-renal obstruction for a number of reasons. You can have stones. You can have a malignancy. You can have fibrosis in the retroperitoneum that can obstruct the ureters. It can be bladder cancer or cancer of the prostate can do it. It can be iatrogenic, right? The urologists say that the OB/GYN doctors only have 3 operations that they do. Tie off the right ureter, tie off the left ureter, and tie off both ureters, okay? So a lot of times they have trouble identifying those structures at surgery, and the patient comes in with hydronephrosis, and then they find out, well, they tied it off at surgery, okay? So now in terms of recognizing post-renal failure, again, you've got to recognize it based on the history of the physical, the clinical circumstances. You will look for evidence of hydronephrosis. Okay, so if you have, let's say you have a stone down here that's obstructing the ureter, you'd expect the ureter to be dilated. Okay, proximal to the obstruction. So you would get an ultrasound of the kidneys to look for hydronephrosis. You're looking for basically dilatation proximal to the obstruction. And in terms of the lab values, which I'm not going to talk about now because we're going to talk about it next, they mimic the findings of intrinsic renal disease. We haven't talked about it yet, but we're going to talk about it next. The book doesn't mention that, but the best I could find out, they mimic the findings of intrinsic renal disease. So in terms of the serum BUN, creatinine ratio, fractional excretion of sodium, all that stuff, it will look like intrinsic renal failure. Okay. Okay. Finally, the third category is intrinsic renal failure. As we said, they divide their treatment of intrinsic renal disease into the tubular interstitial diseases and the glomerulopathies. And I'm going to talk just very briefly about, have you started renal yet, or? No, it's not part of it. Okay. So we'll talk just very briefly about some of the glomerulopathies, some of the syndromes associated with the glomerulopathies, and before we move on to the next topic, okay? So, the first category of clinical presentation in patients that have glomerular disease can be acute glomerulonephritis. So patients can present with acute glomerulonephritis. And we talked about some patients that can develop acute glomerulonephritis when we talked about pharyngitis, and we talked about the importance of recognizing pharyngitis in order to prevent the development of acute glomerulonephritis in patients with streptococcal pharyngitis. These patients have an abrupt onset of hematuria and proteinuria with a reduced GFR, and they sometimes recover renal function. Okay, they can go on to recover renal function. They can recover normal kidney function. The second category is RPGN, or rapidly progressive glomerulonephritis. In this entity, the recovery does not occur. So worsening renal function occurs. That's irreversible, and patients develop complete renal failure over weeks to months. And there are certain diseases that are associated with the development of rapidly progressive glomerulonephritis. The third category is chronic glomerulonephritis. So a certain fraction of patients who develop, remember we said that in patients that develop acute glomerulonephritis, they can recover complete function, but a certain fraction of patients with acute glomerulonephritis develop a slow progression of their renal disease, which eventually results in chronic renal failure. So chronic glomerulonephritis is a third manifestation of glomerular disease. The fourth is nephrotic syndrome. And nephrotic syndrome is characterized by a quartet of abnormalities. You have, this is discussed in your book, they do a good job. You have edema, proteinuria, hypoproteinemia, and hyperlipidemia. And the thing you have to realize, the thing that makes it easy to remember that, is that the primary disturbance is the proteinuria. Okay, and nephrotic range proteinuria, I think, is 3.5 grams per 24 hours. I think it's 3.5 grams in 24 hours. Yeah, 24-hour urine protein excretion greater than 3.5 grams. That's the primary disturbance. Everything else follows from that. So they get hypoproteinemia because they're losing protein in the urine. They get edema because they have no oncotic pressure or very low oncotic pressure, and so they develop peripheral edema. And they get the hyperlipidemia, hyperlipoproteinemia, because the hypoproteinemia stimulates protein synthesis, including lipoprotein synthesis, in the liver, as the liver tries to combat this situation of decreased oncotic pressure. Okay, so everything else is secondary to the proteinuria. Okay, but there's a quartet of the quartet that we talked about. That's the fourth manifestation of glomerular disease. And finally, the fifth one is sometimes patients just have what are referred to as asymptomatic urinary abnormalities as a result of their glomerular disease. So they can have, for example, hematuria, or they could have non-nephrotic range proteinuria of a lower quantity, but their GFR can be normal. They don't have any edema. They don't have any hypertension. They're otherwise normal. I'm just going to try to tie some of these clinical presentations to some entities that you'll then read about. If not in this book, you'll read about them later on. So with acute glomerulonephritis, one cause that we've already talked about is post-streptococcal glomerulonephritis, okay? In terms of rapidly progressive glomerulonephritis, an example of a disease that can produce that is Wegener's granulomatosis, midline granulomatosis. Of course, chronic glomerulonephritis you can see in any disease that causes acute glomerulonephritis, so we don't have to talk about that. Nephrotic syndrome you can see, for example, in patients that have diabetes, or patients that have intrinsic renal disease, idiopathic nephrotic syndrome, and that's discussed in your book. They talk about three different types, three different pathologies that you can see as part of idiopathic nephrotic syndrome. And then the most common cause of asymptomatic urinary abnormalities is IgA nephropathy. IgA nephropathy. Now, any questions about glomerular disease and the nephrotic syndrome? Now, glomerular disease can also present with nephritic syndrome. And these patients have hypertension and azotemia associated with hematuria and proteinuria. And again, the things to remember are the hypertension and the azotemia, the hypertension, and the hematuria, and that would distinguish it from that would distinguish it from nephrotic syndrome. And that's the acute glomerulonephritis that we talked about, and the rapidly progressive glomerulonephritis that we've already alluded to. So that's just to tie in that section of your book with those entities that we talked about: acute glomerulonephritis, rapidly progressive glomerulonephritis, and chronic glomerulonephritis. All right, any questions about pre-renal azotemia, intrinsic renal disease, post-renal disease, how to recognize each of them, how to distinguish them, or some of the different, things that the differential diagnosis of some of these things? Any questions about anything that wasn't made clear? Oh, yeah. I did not, if you look at figure 3.2 on page 49, what I didn't mention, the table mentions it though. I talked about the indices that you see in pre-renal azotemia. With intrinsic renal disease, the BUN creatinine ratio is lower, so it's usually on the order of 10 to 15 to 1 as opposed to greater than 20 to 1. The urinary sodium is going to be higher than 40 because, again, these kidneys are dysfunctional. And so they should, they're unable to hold on to sodium, and so the sodium concentration is going to be in the urine is going to be higher, and the fractional excretion of sodium is going to be greater than 2%. And those are the same numbers that you'd expect to see in patients that have post-renal azotemia. Okay? So if you're given a patient and told that he or she has pre-renal azotemia, and you're given a list of lab values, you should be able to pick out which lab values belong to that patient. Or if you're given a set of lab values, okay, and you're asked, what does this patient have? What type of renal failure does this patient have? You should be able to say, well, he's got intrinsic renal disease or post-renal disease or whatever, okay? All right. Let's talk about chronic renal failure. Are we going too fast, or is this okay? All right. Sometimes patients come into the hospital. Yeah, go ahead.
Can you repeat what you said about the hypotension?
Hypotension. Today? Or-
I don't know. You said something. You mumbled it. So I'm guessing it was hypotension. Something about the nephrotic syndrome.
Nephritic syndrome, maybe? Nephritic syndrome, the nephridities, the patients that have glomerular disease that presents not as nephrotic or asymptomatic urinary abnormalities, but if they present with a nephritic type presentation, either AGN or PSGN or chronic glomerulonephritis, they have hematuria, they have hypertension, not hypotension, and they have azotemia. Okay? Is that it? Was that it? Yeah, patients who have glomerular disease, they can present with, how do they present? They can present with nephrotic syndrome, they can present with asymptomatic urinary abnormalities, or they can present with a nephritic syndrome. And the nephritic syndrome can be either acute glomerulonephritis, or rapidly progressive glomerulonephritis, or chronic glomerulonephritis. Does that make sense? Okay. So when patients come into the hospital or the office and they have an elevated serum creatinine, they have a creatinine of 3 or creatinine of 4, and let's say this is the first time you're ever seeing the patient, okay? If you have an old lab to look at, that's great, because then you can, especially if it's a recent old lab, because then you can decide, am I dealing with acute kidney injury, or am I dealing with chronic renal disease? Because this creatinine is 3 today, it might have been 3 a year ago, it might have been 3, 10 years ago, 5 years ago, whatever. Or it might have been a week ago, it might have been 1. Okay, so the question is, how do you decide? If you have an old lab that you can look at, that's great, the history may help you, but some other things that you can look at to try and distinguish between, am I dealing with acute renal failure or am I dealing with chronic renal failure, would be, for example, do they have a long duration of symptoms? Have they been symptomatic for a long period of time? That would suggest chronicity. If they have anemia, remember the kidneys, as they mentioned on the first page of the chapter, but you'll also see as you go through the readings, the kidneys play a role in terms of hematopoiesis because of their production of erythropoietin. So anemia is a later manifestation of kidney disease. It suggests more of a chronic picture than an acute renal failure. If they have hypocalcemia and hyperphosphatemia, that also suggests more of a chronic condition. Of course, if you, like I said, if you have prior creatinine measurements, that would be the gold standard. That's what you'd want to look at. And the other thing you can look at is kidney size. The patients that have chronic renal failure, kidneys generally shrink, okay, except if they have diabetes. Okay, if they have diabetes, then all bets are off. Okay, but all other things being equal, if the kidneys have shrunk, then it would be possibly an indicator of chronicity and chronic kidney disease. We talked about some of the indications for dialysis. We've already alluded to them. And just so you know, even more, maybe more important or equally important, when should you refer a patient to a nephrologist? Maybe dialysis is not yet in the works, it's not a consideration yet, but at what level of serum creatinine should you refer a patient to a nephrologist? And up to date says you should refer them to a nephrologist for a creatinine a male patient for a creatinine of 1.5. So I don't remember if it was written by a nephrologist or not, that chapter, but 1.5 is what they say you should refer the patient to a nephrologist for. Okay, just a couple more things to flesh out the book's treatment of chronic kidney disease. Chronic kidney disease, the definition, according to Up to Date, is based on the presence of either kidney damage or decreased kidney function for 3 or more months, regardless of the cause. So it has to have been present for 3 or more months. It's characterized by a GFR or glomerular filtration rate of less than 60 mils per meter square. And this is usually estimated using the measured or calculated creatinine clearance. You guys know the formula for creatinine clearance? I don't think I'm going to ask you to calculate this on the test, but it's 140 minus the age, put that in parentheses, times the lean body weight in kilograms, all divided by the creatinine in milligrams per deciliter times 72. So let's just make something up. Let's say somebody's 60, 140 minus 60 times the lean body weight, kilograms, times 70, let's say 70 kilograms. Divided by the serum creatinine times 72. So let's say the creatinine is 1 times 72. So somebody do that. It's 80 times 70 is 500. What? 560? No, 5,600 divided by 72. So what does the creatinine clearance work out to?
77.8.
Okay, so that would be the calculated creatinine clearance. And if it's a woman, you have to multiply it by 0.85 because of the lower body mass. Let's see. So the duration greater than 3 months, GFR less than 60 mils per meter squared, and then some type of kidney damage, that's the third criteria, which they define as structural abnormalities or functional abnormalities other than a decreased GFR. And so an example that they give you is albuminuria, or a urine albumin to creatinine ratio of greater than 30 milligrams per gram would be another criteria. Patients can develop chronic kidney. Did you have a question? Somebody have a hand up back there? Patients can develop chronic kidney disease, again, from tubular interstitial disease or from glomerular disease. It can either be a primary glomerular disease or it could be glomerular disease as a result of a systemic disease.
What page are you on?
I'm still on page 51. I'm trying to supplement some of the stuff that's in the book. I'm going to talk a little bit about the evolution of chronic kidney disease and how the physiology and the pathophysiology evolves. So you can roughly divide the course of kidney failure. Let's say this is time and this is renal function, okay? Okay, you can divide it into three. The early part is going to be called diminished renal reserve. The middle part is called renal insufficiency. And then the terminal part is going to be called renal failure or end-stage renal disease. Say that again? Yeah. Diminished renal reserve, renal insufficiency, and end-stage renal disease or renal failure. And this is true not just about the kidneys, it's true of almost all organs, right? We talk the same way about the heart probably. Let's talk about some of the changes that are noted in kidney function over the course of time. So one of the things that is lost early on in kidney disease is the ability to concentrate the urine. That's lost relatively early on. After that, the kidney loses the ability to excrete phosphate, acid, and potassium. And only when renal failure is advanced and the creatinine and the GFR is less than 10 mils per meter square, then the ability to dilute urine is lost. So the ability to dilute urine is lost last. Patients who have diminished renal reserve generally don't have any symptoms. Even patients who have mild to moderate renal insufficiency may be asymptomatic. You can have nocturia, again, because of the loss of the ability to concentrate the urine. I want to go for about another 10 more minutes, okay? And then we'll stop. Is that all right? Okay, so let's talk. I'm still on page 51, and let's talk about figure 3.3. Some of the changes that are seen in serum chemistry in patients that have renal failure. We talked about how the importance of kidneys in the maintenance of normal serum potassium and normal serum pH. They also mentioned magnesium. It is important to recognize that patients with renal failure have trouble excreting magnesium, and so you have to be real careful about giving them any kind of product that contains magnesium, including magnesium containing laxatives, because you can make them magnesium toxic. Same thing with phosphates, where they're often treated with agents to lower the phosphate. In terms of on the right side of that figure, you see that patients with renal failure develop hypocalcemia. We're going to talk about the genesis of that in a second. They have a fall in their, decrease in their ability to produce erythropoietin, and so it's usually associated with the anemia of chronic renal failure. Okay. and they have hypovitaminosis D. And it pays to take a second here to talk about figure 3-4 at the bottom of the page. What you see is that the primary disturbance in patients that have chronic renal failure is a fall in the serum vitamin D, because the kidneys are responsible for, vitamin D is like 125 dihydroxyvitamin D, and I can't remember whether it's the 1 or the 25 hydroxy, but one of those hydroxy groups is slapped on by the kidneys. And so when the kidneys fail, then you don't make vitamin D anymore. So you get hypovitaminosis D. The vitamin D, its role is to promote the mineralization of new bone. Its role is to promote the mineralization of new bone. And so everything that vitamin D does is coordinated to increase both the serum calcium and the serum phosphorus. Okay? Because you need to mineralize bone, you need calcium and you need phosphorus. Okay? If you remember why vitamin D exists, it'll help you. This way you don't have to memorize what it exists to mineralize bone. Okay? So what happens with patients that have a fall in vitamin D is that there's a fall in serum calcium. Okay? Because vitamin D encourages increases in serum calcium and increases in serum phosphorus. So if calcium goes down, so what's going to happen? Well, the parathyroids, I know we're talking about stuff we haven't talked, we're alluding to stuff we haven't talked about yet, but the parathyroids, I think you probably talked about physiology, they're responsible for calcium homeostasis, and so they're going to sense a drop in the serum calcium, and so they're going to pump out PTH. Okay? And so that's why patients that have renal failure, okay, they develop secondary hyperparathyroidism. So the PTH is elevated, as you can see in figure 3.3. They get secondary hyperparathyroidism. And they can get bony changes as a result of that. This also explains why patients that are in renal failure are generally treated with vitamin D and calcium supplementation, and with phosphate binders sometimes. All right. I think I'm going to stop there. Anybody have any questions about anything that we talked about today? All good?
Can I have your notes?
Are y'all going out for lunch?
I'm gonna have to re-listen to it because I feel like my stuff is everywhere. But yeah.